It is often said that for a village to get good healthcare, it's actually easier to build better roads rather than find a better doctor.
Algorithms that have been developed in the Western population may not apply readily to an Indian situation.
First time, there is a dengue case in Ladakh.
It should not be just a feel-good philanthropy, it should be a do-good philanthropy. The only difference between men and boys is the price of their toys.
We live in interesting times right now because, on the one hand, the promise of technology to solve problems in healthcare are actually unprecedented. And it's also changing at a pace that is far rapid and has a lot of innovation energy behind it. But at the same time, there's this continuous double-edged sword risk that what will create massive gains will also create massive inequality, and the growing divide in healthcare will actually sort of not be something that we can bridge as technology evolves. At the same time, the state capacity to be able to understand the role of technology, to ensure equity, to build regulation is also evolving. And it's always a lagging graph. And hence, as we dream a healthcare system for 1 billion people, how do we get this technology imagination, the system readiness, and equity becomes a challenge. And talking about that requires somebody who understands medicine, who understands health systems, and who also understands policy and government. So it's amazing that you are with us, Srinath, today. You've had a chance to be a physician and a doctor. You've had a chance to work in health systems as part of your role in PHFI, and you've also engaged with governments as well. So it'll be great to have your perspectives in this conversation.
Yeah, thank you very much for that lovely introduction. I'm glad you didn't say that among the various things that you attributed to me, that I'm technology proficient, because my children would violently disagree. So, but nevertheless, I do understand the role of technology in health and healthcare.
Yeah.
So, look forward to a conversation.
I wanted to prime this conversation,
Yeah.
Srinath, on this idea of what is equity in health. It's understood in very, very different ways. If you had to describe what equity looks like and what it is, how would you explain it?
Equity is usually defined as access to everybody to the needed services that have to be provided for them to lead a fairly healthy and productive life.
Right.
Now, the problem, of course, is that equity has always been defined in terms of equality of access or equality of opportunity. Whereas many of the conditions that determine whether you're healthy or not are also influenced by a number of social circumstances.
Correct.
Social, economic, environmental, and commercial determinants of health have a profound role. So, what we really require is not just equality of opportunity, saying that, okay, these are the services that we'll provide everybody, you have a right to access them. That's good, that's necessary, but that's not sufficient.
Correct.
You also need equality of circumstances, which means that what kind of socioeconomic circumstances have you been born in, brought up in? What kind of educational opportunities have you had?
Right.
What kind of occupational income could you earn? What kind of social discrimination you were subjected to? All these determine also how healthy you are and how much you can access the opportunities offered to you by a health system.
Right.
So unless we combine both these dimensions, the horizontal, which is common to everybody, where all services are being provided to everybody, but also a vertical dimension in which additional care or additional resources will have to be provided to people who have experienced health inequity,
Right.
and who still may not be able to take advantage of the opportunities provided to them because of the circumstances that are keeping them down.
Correct.
So, unless we really take the broader dimension of equity,
Right.
we are unlikely to provide full universal health coverage. Yeah, I mean, you have to look at each element wherever a particular intervention is needed
Right.
to protect health, to promote health, to preserve health. All the interventions required are needed, which means that we are taking a broad view
Correct.
of how the health system should function in tandem with the social systems and also at the same time look at specific interventions which take care of specific needs. They're not mutually exclusive.
So health systems, ideally, in taking the same example of a construction worker, should not only make sure that the right medicines and support and care is provided, but there is also an advocacy with the construction industry to say occupational health and standards for safety of these people, worker well-being, working hours should be managed.
If you take a person with disability, for example, there's no point in just saying that I'm going to provide you an appliance which makes you move a little better. Unless you actually change the road conditions, you build ramps, you build accessible buildings, you build multiple stairs which people can't easily climb, you don't build ramps, then you're not really providing them the opportunities.
Got it.
So I think you will have to address all of the elements and certainly try and build in multi-sectoral coordination wherever needed. But within the healthcare system itself, you have to focus on certain issues where specific solutions can be offered by the health system.
Got it. And you've had a longitudinal view to this issue of equity over the last few decades. Do you think things are getting better overall? Are there parts where we've moved forward? And are there parts where we're probably moving back?
There's no doubt that things are getting better. But as the rugby coach of the New Zealand rugby team has said, better is never permanent. So you need to be better every day.
Well, that's a good quote. I'm going to steal that one.
Yeah. So therefore, you have to make sure that you continue to improve. And that's particularly necessary in an area like health, where not only new opportunities are rising, like technologies that you mentioned,
Correct.
but there are new challenges. We have an aging population.
Of course.
Non-communicable diseases are on the rise. Multiple morbidities. It's not just one. If you take a 60, 70-year-old person, there are many systems in the body which are now not functioning optimally or even diseased. So there are multi-morbidities. So you have to be constantly adaptive. And for having that complex adaptive system within health itself, but which has to now also interact with other complex adaptive systems. I mean, the environment,
correct,
food and agriculture, which determines the kind of nutrition you have. Education system, road transport, urban design in the era of increasing heat.
Correct.
All of these are going to be important. But as I said, you have to look at the big picture, try and integrate the elements, but at the same time focus on specific problems where directed solutions can offer immediate benefit.
Absolutely. And just building on what you said, I was recently reading that for the first time, there is a dengue case in Ladakh. Which is a case that's never happened before.
Because as climate change is happening, as there is increasing heat, and particularly there's also increasing moisture,
correct,
then heat and humidity become major problems in multiple ways, not only affecting the human beings, who are going to be getting a lot of effects of heat. But as humans lie listless in the heat, the mosquitoes become athletic and climb to greater heights.
Wow.
So that's how they're now reaching higher heights. Whether it's Ladakh or in sub-Himalayan regions or elsewhere, they're spreading farther, faster and higher. So that's why you're getting a lot of not only dengue, but chikungunya, malaria.
I mean, I would have never imagined that the behavior of mosquitoes is changing. Because of this. It's very, very fascinating. One last question on this before I want to bring in the role of technology. I want to talk about state capacity. I mean, sometimes I worry that even to do the basic things like vaccination is a challenge today. Like India sometimes responds greater to crisis than the everyday activities. But when you bring in this whole element of the multidimensionality and climate change, etc., how do you look at the state capacity for us to be able to address some of these things?
Well, states will have to develop capacity because they are going to have to deal with these challenges.
That's right.
But the state should not believe that it's the only actor that is needed for providing the solutions. It does take in the private sector, sometimes without adequate planning of how to manage the public-private partnerships, both in design and execution. But the whole resource of citizenry of community-based organizations. You need the citizens to become partners as well.
Right.
And unless you actually bring in the citizens in multiple ways, there are community-based organizations, then there are local self-governments. All of them have to be engaged in a meaningful manner in order to deliver. So, and secondly, of course, even within the state itself, you have to bring in much better coordination between the center and the states.
Right.
And you have to actually work much more at the district level.
Yeah.
Everything can't be engineered from the top.
Absolutely.
So what you need is a consultative policy development at the central level, then planning at the state capital level, and implementation in a decentralized manner at the district level.
That's right.
Only then you'll be able to actually reach the people you need to reach with the kind of solutions that are well delivered.
Excellent. I want to pause this piece because I think this is a great framing, saying where does policy happen, where does planning happen, where does execution happen, because I want to overlay it to technology. I want to switch gears, Srinath, and get your
Sure.
thoughts on the technology landscape. I mean, interestingly, I've been at this for the last 5-6 years personally on multiple projects. The pace of change and the entrepreneurial energy around healthcare innovation today in India is actually very impressive. There is an imagination that the potential of technology can solve for health challenges at scale. What are your thoughts on where we are going and what is exciting?
Technology can be really transformational. See, when we look at health and look at the broad domain of universal health coverage,
Right.
then we are looking at coverage in terms of what proportion of the population is covered, and we want it to be universal. We are looking at continuity of care. We are looking at connectivity of care between different levels of care.
That's right.
We are looking at both chronic and acute care. We are looking at cost of care. We are looking at quality of care. Technology in each of these areas can provide a great deal of assistance. It can help you reach places which were previously inaccessible.
Right. Can you give me an example?
I mean, rural, tribal areas, for example. Tribal areas were previously inaccessible. Rural areas had limited coverage compared to urban areas. You can reach all of those places. And if people are actually confined to home because of disabilities or something like that, technology can actually reach you at home to provide care at home. And you can have people also taking care of their own health. Right. In a sense, it can be self-care, it can be family-assisted care. So, in a sense, your reach is tremendously enhanced. Then you can also reduce the cost of care. I mean, people don't have to travel far distances now.
Yeah.
They can get specialist advice even in primary healthcare center and perhaps even at home. You can get through telehealth services or even mobile health.
Right.
So, and then you can get quality of care also improved. People can actually see and now easily find out what kind of diagnostic tests they must have.
Correct.
How to interpret them. What kind of therapeutic procedures are preferable to others. So the moment you can enhance knowledge and democratize the health system by enabling people with knowledge, then your technology can be truly transformational. And you can also reduce costs of care in very many ways. So I think properly used, technology can be very helpful.
Yeah.
But that also means that people will have to be much better educated. And when I say people, I'm not only talking about the common man or common woman, I'm talking about people within the healthcare system itself.
That's right.
Right from the frontline health workers to the super specialists, they have to be educated on how to use the technology and how to interpret the results of technology.
Correct. I want to stay with the technology landscape because you gave so many examples, but to just maybe build it from my understanding, there's one element of it which is better diagnostic tools that can travel far, give us better accurate results. So, which means you can get a community health worker to go home and test for a wide range of things with a fairly great accuracy. There is telemedicine, which is getting access to an expert to a location where they cannot reach directly, but remote access is possible. And today, the numbers on telemedicine are actually growing in India. Then there is health information portals and services, which is for me to even understand what does this look like, etc. What possibilities do I have? There is democratization of health information systems, and then there is, of course, screening solutions, etc., which are more looking at the landscape and saying, what other categories of health and technology landscape are we missing?
One of the critical areas that we must actually sound caution is that we cannot become blindly dependent upon
Of course.
technologies.
Of course.
We have to combine a greater understanding of the clinical situation also, and sometimes the context where the studies are being performed.
Right.
Now, algorithms that have been developed in the West
Correct.
have been done on Western populations, where the nature of disease conditions as well as the nature of the health system are different.
Correct.
Indeed.
Correct.
And we know purely from Bayesian analytics that the prior conditions have to be taken into account when you interpret any test result.
Yeah.
So you have to develop a lot of algorithms using our own data as much as possible. Till that becomes available, then you do depend on other algorithms that have been developed elsewhere.
Right.
But still you have to apply your own judgment of the context.
Correct.
And we have to tap that knowledge not only for our own benefit, but for benefit of global science.
Yeah.
I mean, depending upon only selected Western populations to determine how humanity is healthy or how humanity is diseased and how the humanity should live, I think is a very narrow definition.
Which also sort of brings me to another benefit of technology I've been thinking about, Srinath. One is, of course, the direct benefit, which is the first order benefit, which is today, like you said, I wake up in the morning, I look at my watch and say, have I rested well? And is my heart rate okay? I finish a run, I ask myself, is the abnormal heart rate too high, etc. But the second order benefit is that because technology enables observability, because not only are you collecting the data, but the data can actually be aggregated, we can get population scale aggregated numbers as well to say it's an incidence of a particular condition, let's say diabetes or health behaviors, more chronic in some locations versus other locations, etc., and more intuitive.
Absolutely. Absolutely. You can get geographic, gender, socioeconomic, and age-wise, how the patterns are changing. Even for outbreak of an infection, you don't have to wait for cases to be always landing up in hospitals.
Correct.
You may be able to get from primary care, or you may be able to even get from the pharmacy, whether suddenly there's an increase in the purchase of anti-fever medicines, antipyretics.
Correct.
So you can tap all of that and say, okay, these are early alerts, something is going wrong, unusual here.
And I always use this example that today the Pollution Control Board is putting sensors everywhere to measure air quality. Every home has air quality data today, right? Because of technology. So even if you aggregate air quality data from 15 places where we have information, we get a much richer picture than the 10 sensors that the Pollution Control Board might put in different parts of the city.
Yes, we'll also tell you as an epidemiologist, which I am, apart from being a cardiologist, that you need diversity. Unless you build in that diversity, the generalizability of your findings is diminished.
Correct.
So with technology, you can do that. You can get large numbers. You can also get diversity of the population groups. Just to give you an example as a cardiologist,
please.
If you do a stress test and you get a 2 millimeter ST segment depression, horizontal, that's usually diagnostic of coronary obstruction, which may require further tests, angiography, maybe surgery, maybe stenting, whatever. But you can get the same 2 millimeter ST segment depression in a 60-year-old diabetic male smoker, and where you can say with a very high level of certainty, more than 80%, that this person will have obstructions in his coronaries. Whereas you can get the same 2 millimeter ST segment depression in a 24-year-old woman with anemia, and you will say, most likely she doesn't have obstruction. This is a false positive. Now, that's something you're saying on the basis of experience.
That's right.
But unless you build in the prior probability, you will not be able to really judge only on the basis of the test result.
Yeah.
If you interpret only the test result,
Yeah.
then you'll send a lot of people for unnecessary angiograms.
Exactly.
So that's why the context becomes important.
Yeah.
So with the technology, you need to build in what the population profile is.
Yeah. I want to use this context that we said, Srinath, now, which is we spoke about what is equity. We spoke about what is the emergence of technology from everything from diagnostics to health records to all of that. We want to talk about what are equity risks that technology can enable. The often understood examples are access to devices and connectivity. That I don't have internet, I don't have the device. Women use lesser devices than men, that causes problems. But what are other forms of equity risks that can emerge because of digital introduced in healthcare?
See, obviously, lack of connectivity, lack of devices, lack of digital literacy is also going to be, all these are going to be important problems for ensuring the technologies are effectively and equitably
Correct.
Delivered. Now, people, particularly who are elderly, may not necessarily be very digitally literate. People in rural areas compared to urban areas, digital literacy is about 24% or something like that in rural areas, whereas it's about 65% or something like that in urban areas in India. The other element, of course, is in terms of equity, the whole area of health system being able to interpret the results of digital technologies appropriately and provide the right kind of care. If you are in a primary healthcare center where you have physicians who are not quite well versed with how to interpret the results, then even if they're digitally literate, the patient doesn't get the right kind of care.
Right.
It's not just digital familiarity,
That's right.
but true digital literacy in terms of understanding what the plus points and the minus points of that particular digital technology are.
So, just to bucket what we talked about,
Sure.
I see four broad risks. Right, one risk is the risk at the level of infrastructure, that we are working in populations, working with people that don't have the device, that don't have the network, that don't have the connectivity. The second is the context risk. We don't have data that is relevant to their context or elements that are relevant to their context for them to be able to accurately use the past behaviors, etc., to be able to make that happen. Third is the awareness and literacy risk, which is that they don't have the awareness digitally to be able to understand, use technology. It's not an infrastructure problem. And then there is a provider level risk, which is that the hospitals that they go to or the public health systems that they go to don't have the full ability to leverage digital and provide them the right insights. Would this be a fair summary of the four levels of risk?
I would agree. See, when we talk to our research fellows, we tell them the purpose of research is to generate what we call context relevant,
Right.
evidence informed, equity promoting, culturally compatible, and resource optimizing recommendations for policy and practice. All of this will apply to technology.
Excellent. That's a very, very good framing.
Yeah. For example, how about the people receiving the technology? Are they, first of all, scared of the technology?
Of course.
Are they worried about the misuse of the technology, results of technology? What is the trust in the technology?
Correct.
All this matters there.
Yeah.
So you need both quantitative and qualitative research over there.
Yeah.
It may not be context specific. As long as the context is comparable,
Right.
then the results may be portable. But if the contexts are wildly different,
Exactly.
then the results cannot be superimposed and automatically transferred.
Correct.
Then the third is it resource optimizing? Both in terms of use of financial resources
Yeah.
and in terms of human resources.
Right.
Does it save money? Does it save human effort?
Yeah.
Then that's good. Otherwise, it's not.
Correct.
Then is it also something that is operationally steerable? Is the health system ready to take it up, and is there a lot of capacity building needed
Correct.
for the technology to be utilized? And then, of course, is it culturally compatible?
Correct.
That is not a overriding factor, because sometimes culture is really dynamic and you can educate, but you still have to look into it. Then comes in the question of whether it's going to be easily implementable by the existing health system.
That's right.
And what capacity you have to build within that health system in order to make it work. Make sure that it is a practical solution,
That's right.
which is implementable. Or do you need a lot of implementation science to see what are the barriers and how to make it work? The other issues that will come in are political viability. Who is willing to accept the technology? Who is going to be opposing the technology? Because there will be forces opposing technology. So how do you override all of that? So these issues will come in.
And I think the point that I'm also taking from what you're saying is this resource efficiency is super critical, because sometimes it's intuitive to build for high resource environments, more money, more people, more skills, etc., to design for low resource environments. And I often, in my experience with innovators, have realized that they might not even understand the constraints of what our low resources look like.
Yes,
In
yes,
a large
yes,
scale.
yes.
So then you build it, it works in a nice hospital, then you go down and you realize, oh, they don't have the skill, they don't have this so much amount of money, maintenance costs, maintainability, all of that becomes a very, very massive challenge.
A lot of people have been telling me that the frontline health workers, we are loading them with a lot of technologies, which they're being asked to use. We said it's going to be time saving for them. But for them, the learning curve is sometimes steep.
Exactly.
Secondly, they're being made to do both the manual documentation as well as to use the software.
Correct.
And doubling their work, it's not saving their time. So you have to definitely see how best these technologies are being utilized, particularly at the front lines.
Correct. I mean, I have a real life example because I had a chance to interact with ASHA workers. Almost all of them today go home, get the support of their elder son or somebody in their family to actually enter data. And in most cases, they give up. So the supervisor who's actually monitoring a set of ASHA workers, she goes home, takes everybody's phones and accounts and fills up data, because we assume that all of this is going to reduce effort, but almost always it spills into their home time and other times as well, because the effort is not as minimal as it is for us. So one, I think we started talking about equity, and like you rightly pointed out for me, this idea that equity is just something that you will see as a function of who has provisioning access is very, very limiting. That we take the full context of this person, their social, professional, economic conditions, and say, how do we design that both within the health system and outside? Like you said, how do you zoom out and zoom in at the same time? I think that's very critical. We then talked about how technology can enable that access to equity, because one, it makes it affordable, two, it improves quality, third, it enables us greater coverage, sometimes it ensures that cost effectiveness can actually be achieved in design and so on. But we also talked about very many ways in which that can also result in lack of equity. Like we said, sometimes there is an infrastructure relevant problem, sometimes there's a context awareness challenge, sometimes there is also the system readiness being missing, sometimes the cultural context being missing, sometimes it's just not affordable because not just in terms of money, but in terms of skills and people that needs to be done. What I want to discuss with you now is, knowing these challenges, how do we design a system that can combine the benefits of technology to ensure equity in some form? And you've touched upon some parts of this as we go. So I want to summarize some parts that I've already learned from you. One is really saying, as we look at data, how do we look for diversity as part of this design so that we don't design for one type of population? Second is, how do we design structures that ensure ongoing local participation in terms of holding the system accountable, looking at an embedded review, and so on? Third is, how do we build the skills and capabilities of people in the health system to be able to leverage and benefit from technology? These are some elements that we've touched upon. But if you had to sort of paint a full picture of what that system should look like, what would you highlight?
See, one of the important things is to build, as I said, an efficient, equitable, empathetic, and economically viable health system.
Right.
Whatever we are creating through technologies is not only universally accessible and easily applicable, but they should not be elite capture. So first is making sure that everybody has the ability to access what is available in terms of benefits from technology. Then second is making sure that the system itself is capable
Right.
of applying technologies in the right manner and interpreting the results of any diagnostic tests or the relevance of any therapeutic procedures in the context of the population and the person
Correct.
where you are trying to provide the benefits.
Right.
Which also means that in a federal system like India, you have to develop not just state-specific models, but you have to develop district-specific models, possibly even get down to the block level. Previously, we could not think of that. Now with technology, you can actually get down to the village level. Certainly, you can get down to the block level.
Right.
That makes your solutions much more relevant to the location
Correct.
as well as the time period in which the technology is being utilized.
Correct.
So I think that's going to be the important deal, to build that capacity across the country.
Yeah.
So you cannot have rigid structures. You need to have that flexibility built in the design as well as the delivery of technological innovations, even if the broad picture is being painted by policy at the central level.
Right. A lot of times I worry that the what is clear, the how is a little bit harder. And there are two challenges that I see, Srinath, that I'd love to play back to you. One is this interaction between market and government. Because when you talked about elite capture, my first thought really was that there is financial incentive to do elite capture, to design for the rich, to monetize. And the reason we move much slower in TB while COVID we were able to solve is also because who it affected is different.
Yeah.
And also, government also, in my opinion, finds it hard to regulate private sector very effectively. There is either deep distrust or not enough reins. In healthcare, this is a real problem. Because technology innovation will be led by private sector in some form. How do you see us building this effective bridge between private sector innovation and public sector focus on equity in some form?
We have to deal with the private sector, both in terms of the development of technologies, where they have a definite lead.
Correct.
Though quite often the government also provides them a fair amount of support. I mean, like for example, the development of vaccines.
Yeah.
If the NIV, the National Institute of Virology, had not done the job, Covaxin couldn't have been produced by Bharat Biotech. So it's not that government is not capable of innovations and path-breaking fundamental research.
Right.
But generally, the people who take lead in technology development and innovation are the private sector.
Correct.
But we need to ensure that the benefits of the technology are appropriately utilized for the benefit of the larger population. Therefore, we have to build in some cases, public-private partnerships. But we have to redefine the purpose and the products of that PPP. I redefine PPP as a partnership for public purpose, which means that you have to define what the public purpose is and then say who will deliver what in what way in that partnership. And clearly define the deliverables as well as the accountability measures. Then you can bring in these PPPs in order to really provide the benefit required. And by defining the PPP in that manner, you're not merely saying that PPP is where the public sector and the private sector join hands. You can have two private sector entities also joining hands for a public purpose, well defined. Maybe with a little government oversight, but not necessarily participation. You can have a private sector, an NGO, and the government partnering together.
Correct.
So you can have a diversity of PPPs as long as they are all geared towards a defined public purpose. Then we can actually engage multiple players. There's no reason why two NGOs cannot work together.
Of course.
Or two private sector groups cannot work together. Or an NGO, a private sector, and the government cannot work together. So we can actually create many forms of this kind of partnership, but keeping the public purpose always paramount.
And today we can use technology to be able to help you assess your waist to hip ratio, waist to height ratio very effectively,
Yeah.
to build your awareness on why that is material for you and what
Yes.
you need to do accordingly. We can design health systems like PHCs, etc., where this data is collected so that it's made aware to you. But not only that, at a community level, we can anonymize and aggregate it to say what is the relative risk of this community
Yeah, sure.
for some of these
Yeah,
conditions.
absolutely.
Which then, like you rightly said at some point, a block level can make a decision of saying, hey, my community seems to have a very high risk of this. Can I double down on mechanisms, diagnosis, medicines, etc., for this effectively? And the partnerships for public purpose.
Yeah.
Then we look at where can civil society and industry come in and saying that, hey, here is a problem at a district or a block level. How do we all come together to address this problem, etc.? Gives us a chance to use technology to be able to, in a very contextual way, act very, very effectively. Would that be a
Yeah,
fair?
sure, absolutely. Because, as you said, if we democratize the health system by
Yeah.
sharing a lot of information,
Correct.
whether it's the village panchayat or an urban resident welfare association,
Yeah.
they can actually start looking at how best they can assess the health of their own community
Correct.
and what are the risk factors and how they can modify it over a period of time by tracking and monitoring.
Correct.
Rather than only discussing the stray dog menace,
Yeah.
maybe our resident welfare associations can talk about how to reduce the waist hip ratio or the waist to height ratio better
Exactly.
in the people in the community,
Correct.
or how blood pressure can be better controlled.
Have you seen an example where this has actually worked well in your past experience, or do you have an imagination of what could be an example where some players like this can come together?
One of the examples from a neighboring country, Nepal, for some time they did it. In tuberculosis program, diagnosis was made by the private practitioners, the government doctors, but private practitioners as well. The drugs were provided by the government, but adherence to treatment was monitored by the NGO part.
Got it.
So, because that's a weak link there.
Yeah.
Because if people are not taking the medicines as prescribed. So the community was actually being assisted by community-based NGOs. The technologies are being developed by the private sector, are being funded through a government health program, or being utilized in a government health program. But awareness of the technology and motivation for utilizing that technology, building confidence in that technology, as well as monitoring some of the ill effects of the technology, can all be done by the community-based organization.
Right.
So unless we are utilizing all these resources that are available to in our society, we'll be not tackling the problems in the best manner possible.
Yeah. Actually, that's a very good example because here every organization is playing to their strengths.
Yeah.
The intimacy that the non-profits have, the civil society has to do adherence is a lot easier. Similarly, the tests can be done by private practitioners, which means sourcing becomes a lot more easier. And the drugs anyway is controlled as a supply chain by the government. I wanted to, in this private-public partnership, talk about digital public infrastructure. I think one of the paradigms that we have started in India is to say that create the rails as a public property and then evolve private innovation on top of it, which fosters private innovation. But also in the case of health, ensures that data access is ensured available across players, because one of the risks in elite capture also is elite data capture, which is when they keep the data, then the advantages accrues over a period of time. How do you see the role of DPI or ABDM and all of the conversations in health playing out? And do you think some of that is going to help us achieve the equity conversation that we've been having?
We have to make sure the data which are required are the right kind of data,
Right.
and which components of that can be utilized in an open source manner with others also having access to it.
That's right.
And which have to be protected for certain purposes. But anonymization is something that will be very important, even to make it available to researchers in universities or to the private sector for product development.
Correct.
But as long as we can create confidence that the data are going to be both protected and preserved for later revisitation, is going to be an important element. I think we have to build that confidence over time, and community engagement at different levels in this process is going to build that kind of confidence.
Right, right. This is one part of it, which is the private-public partnership. The second thing is just state capacity. They always say that we have a flailing state problem. We have incredible leaders at the top, but when it comes to service delivery at the bottom, and in the beginning of the conversation, you talked about policy at the central level, planning at the state level, execution at the district level. And as we were speaking, you also talked about pivots that you can make at a block level, at a real-time basis. That requires a certain level of capacity in the system, the state system, to be able to look at it. And it's not just technical, but it's also administrative and functional as well. And as you rightly said in the beginning, I'm just quoting you, it doesn't have to be done by the state alone. State has to orchestrate that partnership rather than trying to do it themselves. But you've also worked with governments effectively. How do you see us building the state capacity to deliver something like this happen?
The state has to be the guarantor of services, but need not be the sole channel for delivering the services.
That's right.
You certainly can engage the private sector on clearly defined terms. Certainly should engage the civil society, community-based organizations and NGOs which have a ground level presence. And ensure, however, that whatever is promised is delivered in the right manner, in the right time.
Correct.
So, therefore, the state actually starts building up these networks and ensures that they perform well. And if there are partnerships that are evolving by themselves, which are likely to be beneficial, the state need not interfere. That if a private sector group wants to engage an NGO to reach a community, ideally, yes, they should blend with the ongoing state health programs.
That's right.
Or at least the district level functionary, the collector must be aware of what's going on there. But you need not stop some of these productive partnerships from proceeding to provide the benefits. And then, but rigorously evaluate what they've done. But I think the important element is to make sure that all through we create open spaces for data to be evaluated for both designing the interventions as well as the evaluation of interventions. And therefore, data has to be accessible. There are some elements of data that may have to be protected.
That's right.
But much of the data, after suitable anonymization, can be put in the public domain. That's very important. And we should not be shy of sharing data. I keep telling people that India's national bird is the peacock and not the ostrich. If we hide our face from the facts, then how are we going to bring about improvements?
That's right.
We have to accept some harsh realities.
Correct.
If we want to set things right. So we need accurate data, we need timely data, we need representative data, and we need actionable data.
No conversation in the current context is complete if we don't talk about AI. There is so much discussion around what AI can do and what it cannot. All of us as consumers have started using AI for I recently did my annual health checkup. I uploaded my health report onto ChatGPT and said, what should I worry about? And it, of course, gave me this, here is what you should worry about, etc. How do you see the role of AI in some of this?
I think it offers a great deal of advantage of the ability to synthesize a large amount of data, which we could not do earlier, and provide us the direction in which we should proceed for a diagnosis or for treatment, and even for community-based interventions, what has failed, what has succeeded, and how well it's been evaluated. All of this you can get in a very, very short time. And it's important for us to understand the limitations of that also, because if the data have been very selectively gathered in certain populations, the portability of the results is not necessarily there for other contexts.
Correct.
But as long as we recognize that limitation, we will be able to utilize how best to apply it. Simultaneously, we need to ensure that we have the ability of the health system
Hmm.
to develop not only the technical capacity to utilize AI,
Hmm.
but also the intellectual capacity to interpret where the results are applicable and where they should be questioned.
Correct. Correct. We talked about state capacity. We talked about private sector participation. One of the elements I also wanted to touch upon, Srinath, is financing. Because financing for this space, both in terms of public financing, private financing, the role of catalytic philanthropy, etc., is very, very unique. How do you see that playing out? Do you see a potential risk in the way we finance it, addressing the risks of equity as well?
I think it's absolutely important that
Hmm.
state plays a role.
Hmm.
But it's also important that since the private sector is a big player in this
Hmm.
and is going to be putting in a lot of money, the state has the ability to advise the private sector which are its priority areas for the health system
Right.
and steer the private sector efforts in that direction
Hmm.
and have an idea right at the very beginning that a particular innovation that is under development,
Hmm.
what is the purpose it's likely to serve,
Right.
whether it will serve the public purpose in a meaningful way,
Hmm.
in which it can be absorbed into the health programs,
Hmm.
and where the health can, where the government itself can become an effective partner in
Hmm.
steering its delivery. Those are the conversations that need to be had.
Hmm.
There will be some blue sky research.
Right.
That's fine. But at some point in time, you'll have to decide what is the potential application likely to going to be.
Correct.
What is the clinical relevance? What is the public health relevance? What is the potential impact going to be? And there, the funding can come in terms of the private sector bearing a substantial part of it, but the state providing some catalytic funding
Correct.
to get a say in the priority setting. But it also makes it easier for the technology to be adopted. It doesn't become an orphan technology.
Yeah. Yeah.
Yeah.
I
I
agree.
mean, just like for medicines, you have advanced market commitments.
Yes.
So you say, okay, you develop this medicine, the state will buy this.
Hmm.
Like that, you can actually make some of those advanced market commitments as well, provided you know into which health program it might be fitted in.
And where do you see the role of philanthropy coming in? You know, the nature of philanthropy in India is evolving fast. We have the CSR, we have domestic philanthropy evolving as well. And there is often a question of in health, where is the highest ROI for philanthropy to put in the money?
See, philanthropy also has to be motivated by a public purpose.
Hmm.
It should not be just a feel good philanthropy, it should be a do good philanthropy.
Hmm.
That means it must clearly identify where this product is going to lead to.
Right.
It's not just the thrill of an innovative technology which looks very attractive. Many people who are developing the technologies or funding the technologies wish to experience. As they say, the only difference between men and boys is the price of their toys. So technology is not a toy. For them to feel elated about that I've got a new toy to show. How is it going to transform their lives in terms of health care delivery,
Yeah.
health promotion, disease prevention, early diagnosis, effective treatment, rehabilitation, palliation. In any of these areas, is this technology likely to be beneficial?
Correct.
And what is the scale of benefit? Is it going to be in a very niche area in which only a few people will benefit? Sometimes you may need technologies for that as well.
True.
For certain types of disability, for example.
Yeah.
But the wider the applicability and the larger the number of beneficiaries, the better it is. So put your money there. And which are the weak points in the healthcare delivery system? Where is it difficult to deliver an effective intervention which is already available with greater reach and benefit?
Right.
So you have to do implementation research to find out where the roadblocks are. So can technology help to remove those roadblocks? So those are the kind of things that the philanthropy should ask. Not saying that I will claim credit entirely for some revolutionary innovation which is going to transform the system. There is already a health system,
Yes.
especially in India, which is functioning. Flawed as it is, it's delivering benefits.
Correct.
How can we make its work more equitable and economically efficient?
Right.
I mean, those are the things that we ought to really look at. You see, the greatest advance in the management of diabetes after the discovery of insulin is diabetes self-care. If people are able to monitor their blood glucose and take care of the medicines and the diet, that has made the maximum difference. Now, blood pressure is even simpler than that.
Yeah.
Why is it that every time somebody has to have blood pressure measured, they have to go to the big hospital,
Correct.
like All India Institute of Medical Sciences, wasting everybody's time and resources, or even go to the PHC for that matter.
Yeah.
PHC also has to deal with so many other issues.
Exactly.
So blood pressure self-monitoring is a thing that can be easily done with the devices. But how do you disseminate the knowledge? How do you build the skills? Here is where appropriate use of technologies can build that.
Absolutely. I think this also speaks to the point about when we know this is a real important problem and a public purpose, rather than building a toy using technology, finding the right, affordable, efficient, effective, empathetic solutions using technology that will help us measure blood pressure at home.
Yes.
Is the kind of investments that public money can facilitate, private money can drive.
Sure.
Because then it becomes like a compass for us to say, hey, where do I put my resources to be able to make this happen as well?
You've been asking me what are the good things in technology that we have achieved. I think the ABHA is a very good thing. It has a great potential.
Right.
The Ayushman Bharat health accounts ensures that you have not only access to your data, that each person has access to the data, that the data is portable even if the person travels from one geography to another geography, moves from one physician to another physician.
Right.
You are able to access all the data, and creation of a very large number of ABHA cards that has happened now
Exactly.
is a very good thing, and we have to educate people how to utilize that facility. Just creating an ABHA card is not enough. Telling them, look, every time you don't have to go and beg your doctor to give you reports because you're moving from one town to another town. You carry your records with you.
Correct.
They're your property.
Yeah.
So these are the kind of things that technology can greatly empower and enable people.
Absolutely. And the infrastructure for doing that is available today.
It's available.
It's not like a futuristic Asimov idea or something like that,
Yeah.
right? Like it's something that we can do today. But thank you so much, Srinath. I think it was a pleasure talking to you. So thanks so much for taking the time.